benefits of intersectionality, if I call that way. One, in matrix lens, it just provides a much more nuanced and complex perspective. Clark and McCall argue that intersectionality provides a different explanation. It just takes you into the sort of complexity. So this is, again, never met a short title I like. This is really a wonderful articulation of this complexity. That this is a qualitative paper that I did with a sample of Black, gay, and bisexual men in DC a few years ago. And this notion, which this is a participant's expression, once you've blended the cake, you can't take the parts back to the main ingredients, right? This notion that it's all mutually constituted. Now, this is problematic too, showing you, because the batter is the intersectionality part. You could argue that the eggs and the butter doesn't really work for this metaphor because that suggests that they're separate, right? So there is, from an intersectionality perspective, there's no eggs, there's no butter, there's no flour. It's all in the mix from the beginning. But I love the I had to go there. Second benefit, opportunities to center the experiences and needs of historically marginalized groups. This is not unique to intersectionality. You're going to find this in many critical frameworks with notions on centering. But I'm going to show you, and I'm showing you examples of PrEP, pre-exposure prophylaxis. I'm an HIV prevention researcher. PrEP is about 97 to 99% effective in reducing HIV. It's been really important. And so this, and I'm going to give you an example of my research in a bit, this is just generally, this is a study, a quantitative study that was done by the Centers for Disease Control. And what it showed is that all of these men had health insurance. And so these are white gay and bisexual men, Latino gay and bisexual men, and Black gay and bisexual men. And what you'll see, the darker bar is for white men, showing that they had higher awareness of PrEP, were much more likely to discuss PrEP with their healthcare providers, and were much more likely to use PrEP, white gay men compared with Latino and Black men, right? And so what happens then when we center the needs of Black gay and bisexual men? What do we learn? Interaction. And third is these opportunities for understanding these sort of intersectional social processes. Things like intersectional stigma, which is relatively new in the literature, and intersectional discrimination. And so I just want to show you really quickly some findings from one of my studies. So this NIH, back in the good old days, like I said, NIH, actually the National Institutes for Mental Health, they requested applications for people who are doing work around intersectional stigma. And so my team and I got an R21, and R21 is a 2-year exploratory grant. And what we wanted to do was develop measures of multi-level intersectional stigma for Black, gay, and bisexual men in Washington, D.C. and Jackson, Mississippi. And we wanted to understand sort of facilitators to HIV prevention, particularly PrEP prevention. And so this is my fantastic team. Tell you about we went from ages 15 to 34. At NIMH, initially we had ages 18 because, you know, you have to spend so much time fighting with the IRB, even with an 18-year-old. But NIMH said, no, we really want you to go younger. And so that's why we 15 to 34, they had to self-identify as Black, cisgender male, identify as gay, bisexual man who had sex with men or report sex with a man last month. They had to live in DC or Jackson, Mississippi. And because this was an HIV study, they had to report that they were HIV. And so what we did is we did interviews, and we used almost verbatim what they told us in these interviews to build a quantitative measure that we would validate. And these are some of the things that men said and what you learn when you center their experiences. We don't need to know about white gay men and more privileged groups. We really don't know what are some of the barriers, what are some of the problems you're having. And these are some of the things that people said. It's not easily accessible. They said without prompting, white men have more resources to get PrEP from their providers. Nobody knows about PrEP. My healthcare provider doesn't know about it, my primary care, and my health clinic only has data and information and so on and so forth. And so then we developed almost as a mixed methods researcher, I think it's so important to develop measures almost verbatim. And let me show you what happened. So we also partnered with another group of doing this sort of HBTN 096, which sort of is national trials. And they got in touch with us. They were interested in intersectional stigma. NIH said, we talked to Lisa Bowleg, her team is developing measures. And so we gave them our preliminary measure. And this is what they did. They took it, they chose, we had 15 subscales that we developed. They took it to Dallas, Houston, Montgomery, Alabama, and Greenville, North Carolina, for 100, and they disseminated our measure to 422 men. And those of you who have taken quantitative measures, Cronbach's alpha, you know, Cronbach's alpha is a really important measure of reliability, internal reliability, how well these sort of measures stick together. It's 0.92, which is damn. So excited. So show you some of the items, you know, these are the items that we generated. There was a lot about individual level stigma, internalized stigma. I was not that interested in that because in a social context of a healthcare provider talking to somebody about you should take this HIV prevention strategy, it's really on the healthcare provider. That's where the power lies. You don't get PrEP. You don't pick up PrEP like at the CVS. Somebody has to prescribe it to you. And so I was telling my team we really need to focus on these sort of larger systems. And so we're doing a paper focused just on the sort of healthcare provider stigma, which is something we don't talk about enough. But this is just, and you can just see the alphas for the different measures. Amazing. All right, I'll jump into that. Okay. So we come to the most important thing you need. This one. I think y'all need to know about qualitative intersectionality research. I take you back to this slide. And as I said, this is what everybody is interested in. And of course, today is research day. So this is what y'all are interested in. Most important thing I want you to know about qualitative intersectionality already. Methods. It doesn't matter. It doesn't matter. It's not about the method. It's really about your sort of epistemological stance about the values that you bring to. And so this is a paper where I was arguing exactly this. This is a 2017 paper of mine where I argued, they asked me to write about qualitative methods. And I'm like, okay, I'll do that, but it really is not about the methods. And so what I write here is research methods are just tools and techniques. That's all, you know, you collect the data, you transcribe the data, you plug it in the software, you know what I mean? But this notion that using qualitative methods, like if you're using that, you're doing progressive work, that is a myth. And the example I have here, I'm trained as a yoga teacher. And so this is the type of stuff you don't start. So akin to the idea that light bulbs and not the electric current coursing through them are the source of the light. It's not the light bulb, it's the current. And it's similarly like this with doing research, whether you're using qualitative, quantitative, mixed methods, that's really the electricity, this stance that you bring. So in other words, qualitative intersectionality research isn't an epistemic stance. That's all it is. It's not about the method.